So I want to give you an impression of our results with the OMNI device, our first year results with a combined canalostomy and trabeculotomy. What we used was the first generation of the OMNI device shown on the left side. The difference is the newer generation has a more ergonomic design, a better handling, as Leon already mentioned. The first generation has two control wheels, and so in my hand, it often was a little bit of wibbly-wobbly procedure, not so easy to introduce. That was improved, not only the control wheel, but also the cannula and the catheter were slightly improved with the generation 2, what makes it easier to handle during surgery and shorten the learning curve. Here is a microscopic image of viscular dilation with a, as Norbert mentioned before, former device, a Viscos 360, that shows the effect of viscodilation with the device, and the way the OMNI is opening Schlemm's canal is equal to that what Visco offers us. So, and we've seen this slide as well from Imran, the structure of the Schlemm's canal and the collector channels with, as shown, there is not only the resistance of trabecular meshwork, but there's also a resistance within Schlemm's canal due to cylindrical structures we can open with viscodilation and with a microcatheter. And we have these valve-like mechanism in the collector channels, which we may open with a viscodilation, and at the end of the procedure, the trabeculotomy that reduces the resistance from the trabecular meshwork itself. So here you can see a short video of the OMNI procedure. So first of all, you see a slightly blood reflux into Schlemm's canal. So at the end of the surgery, that was a combined case with stabilization of the anterior chamber with viscoelastic, but not a proper filling to allow a slight reflux to make it easier to identify Schlemm's canal, a puncturing of trabecular meshwork, and then a slight introduction. And if you look close to the details, you see it's because of the design of the device. We stretch Schlemm's canal, and the curvature of the catheter, it's much slightly smaller than the diameter of Schlemm's canal. So I don't see any risk to introduce these catheter into the collector channels. And on the other hand, you have to place the catheter slowly into Schlemm's canal to prevent an reopening and reintroducing of the catheter into the anterior chamber. At the end of the procedure, you see these blood reflux, you see a blanching phenomenon. If you fill the AC with BSS, and you see over there this blanching effect, especially on the place we introduced the catheter as a result of opening of trabecular meshwork and Schlemm's canal as well. So we have done a prospective trial on over 12 months now. We enlarge it now on 24 months, but we have the results for 12 months for 1 year. The primary endpoint was the proportion of patients with a 20% reduction from baseline in unmedicated IOP. Secondary endpoints were the proportion of subjects with an IOP lower than 18 and higher than 6 over 12 months, and the number of subjects with medication-free treatment of the glaucoma, and the number of second surgical interventions. So we included 34 eyes of 22 patients with a mean age of 65, between 56 to 78 years. 12 of them were female, 10 were male. All of the patients were Caucasians, and 26 of our patients were phakic patients, AVER pseudophakic patients. The procedure was in all cases a standalone procedure. The mean IOP at the beginning of this study was 24.7 after washout, was a maximum between 20 to 32. Mean medication was 1.9, between 1 and 4 different medications. The mean field deviation was minus 3.53, so we treated mostly mild and some moderate glaucoma cases. So here's are the results. We started from 24.7 and we ended after 1 year at 14.7. And what we were able to do was a significant reduction of medication from nearly 2 to 0.4 at 12 months. And what we saw is that the intraocular pressure was nearly constant after surgery over all these period of 1 year. If we have a closer look to the results, as you see in here, the delta, especially from the IOP, was about 12, and at the end of our study was only 6. So we have a consistent effect over all patients with a low complication rate and a significant IOP medication reduction. About safety, the complication rate, what we've seen is in nearly half of the patient, 47.1%, was a hyphema of any size, but any size means there was no hyphema seen more than 0.5 millimeter at the day 1 after surgery, and in no case there was a need of an additional surgery due to the due to a persistent hyphema. We had 2 cases of a hypotony, which solved itself within 2 weeks after surgery. We have had 2 cases of antiosynechia. Imran was talking about the mechanisms in his excellent presentation before. So what we try to do is we add pilocarpine in the first 2 weeks after surgery to prevent it, but we still see a couple of cases with antiosynechia, a low number, but it's possible. So, and we had 1 patient with a lens touch during surgery with no growing cataract after surgery. It was an hyperopic eye, so with a really flat or shallow anterior chamber. So in my opinion, we had a good safety profile with this surgery. So, and if we have a look on the results formally shown in the study design, so 75% achieved and 20% IOP lowering without any medications. So the complete success rate, qualified success with medication, was 91.6%, and 100% of our patients had an intraocular pressure from 18 and lower at the end of the 12 months observation time. 58% had a pressure of 14 and lower. So, and what we achieved additionally was a significant medication reduction. So, as I told before, good safety profile, in my opinion, low complication rate, and the post-op management in this kind of surgery is nearly equal to cataract surgery. So we give antibiotics for 1 week, steroids for 4 to 6 weeks, and as I mentioned, myotics for about 2 weeks in the early post-op period to prevent synechias. So what we need, of course, are long-time data, and I think the next presentation with Simon will show us the results of long-term.